Hello, good afternoon. I don't think I can emulate what we heard just now, but I will make an attempt and try and make a case for doing what we do. And I'll show you, I couldn't find any real evidence that radiologists have published saying these are the patients we picked and we've treated. It's usually been what has been rejected by you guys that we get given, and then we deal with it. So potentially it's already been super selected as the borderline lung function or the patients who you do want to risk putting under the knife. So I've kind of picked up from the data we have. We started working on RFA about 2005, 2006. And this is a collection of cases between 2006 and 2011. About 48 lung nodules we treated by RFA. And of which I had to repeat treatment on 6 of them. The data is from the electronic case notes in these patients. And of these, there were 2/3 were primary lung cancers. Obviously, it's small enough to be treated, but no nodal disease or extrathoracic spread. And then there was a huge spread of patients with secondaries from elsewhere, primarily from the colorectal side of the world, which is what the surgical department in Heartlands does. Lots of colorectal mets get metastasectomy. So they came to us. And there's a spread of small bowel metastasis, renal tumors, adamantinomas, and the like. Now, if I split down the indication of how they pitched up with us, so the big bulk they were too risky to tolerate a surgical procedure or not fit for surgery. They had previous surgery, and therefore we were down the route of parenchymal sparing, or they've had radiotherapy, and therefore they couldn't be resubjected to another dose of radiation. And there was a smaller bunch on which there were purely metastasectomies, and again, parenchymal sparing was the view in those patients. There are a couple of patients who had clearly says poor lung function, and therefore we're not going to touch them. And there was poor cardiac function, end-stage renal failure, patients with dementia, Parkinson's, issues with consenting, and post-operative complications would be too great to deal with. And what do I take on? My cutoff has been the FEV ones less than 35% is where we stop. We are stretching them with the help of the rehabilitation programs. I don't have the exact numbers on what they did after the rehab program. We had 3 patients go through that. One of them progressed while he was being rehabbed and he couldn't have surgery, but the other 2 went on and had successful RFA. If they have previous pneumonectomy, it's a certainly no-no in our experience. There's a team of radiologists in Paris who have done a series of 24 patients, pneumonectomy, so single lung, they've carried on and done RFA successfully. The other are general, and therefore we wouldn't be able to carry on and do anything with them. In terms of the tumor itself, is there something which will stop us from treating? Is there a no-fly zone, so to say, with these cases? We think we don't want to go too close to the mediastinal structures or the major vessels, so we give a 1 centimeter margin. Part of the reason being that you're going to end up with heat sink with the big vessels, or you're going to have disastrous bleeding. You end up with fistulation, which can become problematic post-procedure. So they are the reasons why we kind of stay away from it. And I think my colleagues in radiotherapy probably have something similar, and they probably go around 2 centimeters, no-fly zone, which is again stretched. So what are the ones that we really like? Are tumors which are below 3.5 centimeters. So when I talk to patients, I tell them we have a traffic light system, green, amber, and red. So if any tumor is below 3 centimeters, I say, you are in the green zone. I think I can give you a safe cure. At least for 3 years, we can see the end of this tumor. Once they get between the 3 to 4 centimeter mark, they are in the amber region with higher recurrence. And then as you go into 5 centimeters and above, we're not talking about cure, and it's purely palliating. And as you can see with this graph, you can see how it starts dividing up In the first year, they are reasonably close together, and as they go into the second and third year, it's going away. So 3 centimeters is the magic number which we tend to use for patients which we take on. The other indications that we have been using are, as long as the metastases are less than 5 in total, 3 on the same side. These nodules, if there are more than that, are they progressively increasing in size rapidly? If you have people with lots of metastases, but there's only one which is progressing, then that's again suitable to be treated. The other indications I've kind of mentioned, unfit for surgery and comorbidity. And we also like to work together with other modalities, and therefore patients who've had previous surgery and radiotherapy or metastasectomies are also offered as a complementary therapy. We can also palliate, and for pain relief, including bone metastasis, can be treated by RFA, which we have done one case of. And what is the evidence in the radiology world in terms of radiofrequency ablation? These are papers which are going back in time almost 10 years now. Thierry Debert from France has got a series of 100 patients he published at the time, and they had a 18-month overall survival figure of 71. And these were non-small cell lung cancers and metastases put together. The group from Greco, they were purely non-small cell cancers, 41 patients, which had 87% survival figure at 12 months, which dropped to 57% at 3 years. Lancioni had 100 patients who had 18-month, 91% cancer-specific survival figures. There's a bunch of patients who are purely colorectal metastasis, which show excellent survival rates in the first 2 years, and then from the third year onwards, we're starting to drop off. If you can see, as long as the tumors are less than 3 centimeters, we're still looking better. This paper shows a 2-year period of overall survival figure of 62%, and for metastatic lesions, it's clearly higher at 71%. And if the lesions are below 3 centimeters, 70% survival figures. Now, this is a more recent paper, still in press. 121 patients, stage 1 non-small cell lung cancer, and these were not randomized, but they were selected out based on their respiratory function, whatever was going on, but they got into the 2 arms. 62 patients ended up having RFA, and 59 had wedge resections. When you looked at the local recurrence of these patients, at 42 months, RFA had a 23% recurrence rate, and wedge at 3 years was only 2%. And that looks really bad for us. And these figures lower down shows you the 1 year, 2 year, and 5 year disease-free and survival figures. Certainly, surgically, it looks like the thing to do if you can stretch the limits of surgery to offer surgery for these patients. Maybe if you try and go into the nitty-gritty of why these guys are not doing as well. The patients who are in the RFA arm are tending to be slightly older. Their risk factors seem to be loaded against them in terms of higher coronary artery disease patients, the comorbidities like diabetes, liver disease, they are higher. So that kind of starts to balance against the radiologists. If you look at the comorbidities, the radiologist didn't find anybody with comorbidity of 0 or 1. So we got all the patients who were 2 and 3. So that's 20 and 42 patients there, as against a more even spread in the surgical group. The FEV1s, when you look at it, it looks very similar. 47% for the surgeons, 49.5% for the radiologists. But if you look at the spread, you get from 111 to 27. And I presume the 111s are all the metastasectomies, and the 27s are the primary lung cancers with bad lungs. When you start looking at the tumor size, again, the ranges that we're dealing with are also much wider. And I think these are probably factors. When we treat patients, the degree of clearance that we give around the lesions is very variable. It is difficult to judge it once you start treating the tumor. You hope to give at least a 5 millimeter margin, or maybe more. There are papers coming out saying, depending upon which tumor type you're treating, you have to give 6 millimeters, maybe 9 millimeters clearance around each of these lesions. And as these lesions start to get bigger, your multiple ablation volumes are going to take longer. You do not want to keep these patients under a GA. We do all these procedures under GA currently. We started off under heavy sedation, but they're all done under GA now. The time that is taking longer. This might help if we move to microwave, which takes probably a fourth of the time it takes for radiofrequency ablation to cook these tumors. So that might change how well we can cook and how much more we can cook. In terms of the post-treatment outcomes, the 30-day and 90-day mortality is 0 in both the groups. The adverse events are slightly higher, as expected with the surgical side, but post-treatment performance status has not changed for either group. And this is another busy slide, which has kind of pulled together the patients who had the top bunch. The 8 papers are surgery, which is wedge resection. The middle bunch is radiofrequency ablation, and the last is the new kid on the block, which is SBRT. So if you look in the last columns, slightly zoomed up there, so this is the RFA group, SBRT, and high up there is the surgeons. So clearly, surgery is the way forward if you can get them going there. Radiofrequency is not looking as good as even SBRT looking at the early results. But where do we stand? Have we got something to offer still? I think there is. And like Mr. Roca was saying earlier, you need to ask the patient what they want. And they might decide that they do not want surgery, they do not want to be stuck in bed with an oxygen cylinder. They might want to do something different. And we haven't had any of these patients subjectively say, no, we can't do what we did before. All our patients are back doing what they were within a week. Some patients have had what we call a post-ablation syndrome with fever and unwellness a week after the procedure, but within a week, these guys are back doing what they were. There's ongoing work I'm doing comparing the pre and post RFA, FEV1s, and lung function. The great advantage for us is, even if we have higher local recurrence, they can have another treatment at the edge of the lesion, which is repeatable. And if the new ones appear, we can treat them with preserving parenchyma as much as we can. So I think in conclusion, the way I would like to put it together is, it is a technique which we should use selectively. It should be for patients who are not fit for surgery, patients who choose to have it, and it's eminently suitable for metastasis. I think at least in Birmingham, the SABRE unit do not have funding to treat metastasis. They treat only primary lung cancers. And therefore, local availability will matter. The fact that we can repeat is easier. And it is also available as a salvage for post-radiotherapy. I work closely with our SABRE team and also radiotherapy people, and I've had referrals from them. And similarly, I send patients across to them with patients who I think are going to be higher risk. The location of tumors can be crucial. So central tumors, you don't want to be doing a lobectomy on these patients, so we can very well help with those ones. For SABRE, correct me if I'm wrong, I don't know who's talking from Leeds. I think the lung bases are a bit difficult and tricky. The duration it takes for them to breath hold during the blasts of SABRE, they might be patients who might come to us. And we can pre-optimize our patients. We have a set program for getting these patients through rehab before surgery. Similarly, we can put our patients into that group. And recovery is much quicker, which all our patients seem to like. Sridhar probably has seen this slide, because he did it for me several years ago. So all our patients are through the MDT. They come through it, and that is where we get our patients from, and we look after them as a group. So I want to say thank you to all of you for listening. I want to acknowledge all the hard work my RFA team put in. And most importantly, I think there's one anesthetist who can take this message back to Anna. I'm very grateful to the anesthetists who come and help out outside the comfort of the theater, the ODPs. There's usually a panic when they hear there's RFA going on in CT, who is going to go down there. So I'm very grateful. I'm ready to take any questions from you guys.